Okay, Andy, I think we have a pretty good quorum. Took a little while for us to gather, so I'm happy to get started. Thanks for joining us today. Andy, are you driving slides or? Okay. Um, and it's been obviously some time since we've met. So next slide, please. So these are some of the basic slides that we go over every time about cardio. It's hard to believe we've been around for more than 8 years now. Next slide, please. And today I'm going to start with this brief introduction. I will also be giving the didactic presentation, the Pearl, and leading the case discussion as well. And I'll turn things over to Amanda after that. Thanks. Next slide. So these are our sites, as you're all familiar with. Next slide, please. And this is our project team. Next slide. No disclosures from anyone either related to this presentation or to the project as a whole. Next slide. And if you are eligible for CME, the credit, I do encourage everyone to take advantage of it. Next slide. And maintenance of certification. And Andy has put this slide. Thank you, Andy, for up even last time. I actually have gone through this process just over the last few weeks. I don't believe I can use my participation in this, but certainly you can certainly do that. It's pretty straightforward. They've simplified the processes with the ABFM. Some of you are ABFM eligible. Obviously, many of you are ABIM eligible, and I'm not too familiar with their requirements, but they are similar. Next slide. Remember not to disclose any PHI. Next slide, please. Good. So now we have arrived at our actual didactic presentation. So we're going to talk today about patient experience and what it actually means, how it's measured, and how it may be helpful for you in relation to your QI efforts overall. Next slide, please. So the objectives today are to distinguish between patient experience and patient satisfaction. They are not the same thing. I'd like everyone to be able to describe a couple of tools that are used to measure patient experience, such as CG CAHPS, which we'll go over. And the other thing is, I want you to be able to address areas for improvement for that might come out, not related necessarily to your QI projects, but in your practices as a whole, how you might tackle the issue. Next slide. So we are talking basically about patient or person-centered care. So QI is quite distinct. In other words, I can improve, for example, care for type 2 diabetes by improving the percentage of patients that are on GLP-1s or SGLT2 inhibitors, or better managing patients with chronic kidney disease and type 2 diabetes. No question, I can look at those numbers. But that doesn't necessarily mean that the care that I've delivered is patient-centered. So patient-centered care has quite a broad definition. This is from the New England Journal's Catalyst. You are aligned with the patient goals. It's coordinated. It's comfortable. Patient and family viewpoints are included, and patient is welcome to participate in decisions. Family is welcome in the care setting. It's fully transparent, and fast delivery of information is important. I I think I like to be transparent, but for example, I've been away last few days and there's a whole bunch of epic messages in my chart, and I will be completely transparent and say, look, I'm sorry I wasn't able to get to these. I've been out of town. I'm just getting into my epic inbox now. And I can tell you in my own personal experience that is well appreciated by patients. Next slide. So here is the distinction. Patient experience refers to the interactions patients have with the healthcare system. There are three components: effective communication, respect and dignity, and emotional support. Patient satisfaction is not what the same thing. It's patients' evaluation of the care provided relative to their expectations. Typically, experience is a process measure. Did your doctor greet you? Did somebody greet you in the office when you walked in? Were you taken back to your room in a prompt manner, etc.? Patient satisfaction, however, is an outcome measure. So it's, are you overall, are you satisfied with the care you receive? They are obviously very, very closely related and sometimes difficult to distinguish, as we'll talk about in a moment. Next slide, please, Andy. So here are some examples of experience. Um, how satisfied with your visit today is clearly patient satisfaction. How satisfied are you with the care that was provided to you? Versus the process measure, did your doctor answer all your questions today? Did your doctor explain the side effects of medications that he or she has prescribed to you? Those are process measures, and that's more of the experience of care that you have. They are certainly related, not synonymous, and they are related to quality of outcomes in the sense, indirectly, in the sense that if you are more satisfied, if you have a higher degree of patient experience, you're more likely to have a positive outcome, but not necessarily. Next slide. So here's where we are. Now, what are the expectations for you of your QI projects? We don't expect you to roll patient experience measures or patient satisfaction measures into your QI projects and try to improve them over the short course of this project. That is not going to be possible for the most part. One of my mentees yesterday, I think it was, or the day before, I was talking to her, and she has a project designed to look at outcomes in perimenopausal women with respect to cardiovascular risks. And one of the outcomes she was looking at, it was coronary calcium score. And I discouraged her from including that in her grant proposal because coronary calcium is not likely to improve over the short course of time. Similarly, patient satisfaction or even experience of care, you may not be able to witness a significant improvement. Nevertheless, it's something you may want to incorporate overall into your projects, and I'll talk about that in a moment. So, what influences patient experience and health outcomes? Well, there's a county and health system context. Some counties, some health systems cater to populations that unfortunately have poor experience of care for whatever reason. They don't have resources, and many of our systems here in Ohio are in that situation. You may be caring for patients in a rural area or an urban inner city area, and the challenge there is that you're never going to get a really high degree of satisfaction or even patient experience because there's just not enough providers or not enough resources. So facility characteristics, service type, and patient characteristics are important. Unfortunately, some people are chronically dissatisfied with the care they receive. They're called men, but not necessarily. That's what we think, but I don't think that's necessarily true. But you're not going to change that necessarily. So patients' needs, expectations, and values are important. The experience of care, we talked about the three components. Keep these in mind. Communication. Effective communication is defined as communication uh, that the patient can understand. You know, I explain side effects to my patient. If I didn't explain them in a way, if I said something like, well, I'm going to put you on a statin drug and you may experience myalgias, that's not effective communication for the majority of my patients, right? They don't know what myalgias means. They think of statins as cholesterol drugs, so you're not using the right language. Respect and dignity, I think that doesn't need any explanation, and emotional support as well. And of course, all of these will lead to positive healthcare outcomes, better satisfaction with care, and confidence in the healthcare system. I think this slide is useful because it does distinguish quite clearly between satisfaction and patient experience. Next slide. It's interesting because when we think about QI outcomes and quality measures, we want them to be as objective as possible, right? How many patients were scheduled for a follow-up visit um, within a certain period of time? We certainly don't ask the patient, did you have a follow-up visit scheduled? Because, hey, they may or may not know that. But in terms of experience, we want to actually embrace subjectivity. And that's the distinction that I think is extremely important on this slide. It's, did your doctor explain the side effects of any new medications? That's not subjective and it's not necessarily useful because the patient might recall, yeah, I remember he or she talking about side effects and I didn't know what they were referring to. So if I said to my patient on a cholesterol-lowering drug, one of the side effects you might experience is myalgias. Okay, the patient may recall me discussing side effects, but they don't know what myalgias means. So the better question to ask is, did your doctor explain the side effects of any new medications prescribed to you at today's visit in a way you could understand? Okay, so it's really important to embrace that degree of subjectivity. Next slide. So here's a brief exercise about how we may roll patient experience or patient satisfaction into the care of an individual patient. So let's meet Maria. Poor Maria has been the subject of 3 or 4 presentations I've given over the last week, but hey, she's back again. She's 53. She has a history of hypertension, type 2 diabetes, dyslipidemia, obstructive sleep apnea, and class 3 obesity. She's been your patient for 5 years. Let me throw this question out to her. Let's select a patient experience measure, let's select one of her chronic illnesses. And what kinds of measures of experience? What question might you ask her to get a better idea of her patient experience, not her satisfaction with your overall care and etc. So keeping in mind those 3 measures, dignity, um, and communication in particular, um, and of course, overall satisfaction as well. What might we ask her?
Hi, this is Amber. I think
Hi, Amber. Go ahead.
one of the questions I would ask is, well, I guess now I'm confused. Okay, so patient experience, I was thinking, with your current treatment plan for hypertension, do you feel that it's, supportive of your needs?
Yeah, great. Okay,
Like, are you agreeing to, are you not compliant, but do you understand your current treatment plan? And
good.
do you have any questions or, you know, general ideas about your treatment plan?
I think that's excellent, Amber. I mean, I might make it more specific and say, did your provider answer any questions you had about your treatment plan for hypertension? Okay. That is a very different thing than, are you satisfied with your care for hypertension? So it's more of a process measure. Good. Anyone else? I like
This
to
is
wait a few.
Arpita. Um,
Arpita,
so,
go ahead, please.
did your provider discuss shared the decision planning with you, or make a decision on his own, or just
Excellent.
trying to understand, like, was it a shared decision making, or it's more like
Mhm.
just uh, according to the guidelines?
Excellent. So it would be something like, did your doctor, I mean, you wouldn't use shared decision making necessarily because you may not know what that precisely means, engage you in a decision about care for whatever, one of these conditions. That's excellent. Okay. That's very different again than, are you happy with your care for diabetes or obstructive sleep apnea or whatever? Okay, I think that I am confident you have met that first objective, distinguishing between patient experience and patient satisfaction. So we can move on. Next slide. So let's talk about how these things are measured. Many of you have heard of the CAHPS surveys. This stands for Consumer Assessment of Healthcare Providers and Systems. The clinician and group survey is CG CAHPS. It's a really well-established tool for patient experience developed by the Agency for Healthcare Research and Quality. And we're not going to spend too much time on it. You can look that up. Next slide. This is the actual, this is a link. And I think the only point, the reason I put the second paragraph on there is that it's a frequency thing, right? It's not, hey, I'm happy with my care. It's, does your doctor always explain something to you? Does your doctor always provide you with a discharge summary? It's those kinds of things. So it is an experience measure. And you'll notice that the frequency is always, usually, sometimes, and never. And it helps because if you give people a neutral choice, so some people sometimes might pick that, but usually these are pretty objective. In other words, you'll get meaningful responses. And we're not going to go into how the mean value and score is calculated, but you can always click on this link. We don't have time for all of that. Next slide. I wanted to measure this. I wanted to discuss this particular patient experience measure. This is really important for me personally because it was developed in my department, and not only that, the person-centered primary care measure is an outcome measure. So it is a hybrid of experience and satisfaction. It's been adopted by the CQMC, the Core Quality Measures Collaborative. I was the champion for this, and I'm a member of the collaborative. It is now a CMS measure, and it is really encouraging to see it being adopted all over the country. Dr. Stange and Dr. Etz, many of you know, developed this here in Cleveland. Now, it is an interesting because I think, and I love it because the questions that are being asked have never been asked prior to a couple years ago when we were introducing it to the CQMC. We have never been asked in any sort of QI type of measure or satisfaction measure. So my doctor, an example, my doctor of practice knows me as a person. Isn't that interesting, right? So this is a measure of the overall experience and satisfaction with primary care, and I encourage you to think about using it. Next slide. So how might you implement the PCM Pro? This is kind of a rhetorical question that I can tell you. It is rolled out in many different ways, I think. Right now, it has been rolled out successfully as a pre-visit questionnaire for people who have an established relationship with a provider, etc. But here's the question I wanted to throw out to everyone and see how you might address it as well. So assume we have a challenge with patient experience. You do a survey, and I'm not saying it. Sherry and Bolin and I talked about this. I mean, this is not necessarily part of your QI project, but it's something you may want to do at some point. But let's say you survey 30 of your patients, and the knowledge of my family, my doctor knows my family, is at a mean score of 1.8, which is low. Okay. So, and this is quite common, right? There are many patients whose situation I don't know. I do try to ask all the time, who's at home with you? And sometimes it's I'm by myself, sometimes it's my adult daughter, sometimes it's my sibling, sometimes it's an elderly parent, sometimes it's me and the kids, sometimes me and my husband. But it's important to know that. And if you have a situation where the majority of patients tell you, my doctor doesn't know this information, we haven't discussed it, how might you address this in a practice? Not you individually, but let's say you have 4 or 5 providers. How would you go about improving this? Because it is related to the overall satisfaction with your primary care provider. Any thoughts? Oscar?
Yeah, Dr. Rao, do you think I do ask some personal questions of my patients, and sometimes I get the feeling that they may feel it's too intrusive.
Mm-hmm.
What's your thoughts on that?
Yeah, it's a great question. Great point. I do not personally say, okay, let me get your marital situation, or let me see, are you married? Are you single? Are you divorced? Are you widowed? I never ask questions like that. I don't think that's helpful. But none of that really gets at the issue. Why are we asking this question? We're trying to ask them because we want to know what their social supports are, right? And sometimes I find it extremely meaningful because a lot of my patients are older, and it's very, very distressing to me to hear that they are completely alone, right? They can't get out and meet someone. And that influences the care that I provide to them. I'm not going to say, hey, make sure you and your friend go for a walk if there's no friend to do that with, for example. So that's why we ask this question. We're not trying to be intrusive. So I ask, okay, so tell me about who's at home with you. Is there anyone at home with you? And the other question I ask is, how do you spend your time? And those are sometimes really, really meaningful. Fortunately, most patients do have that sort of social support. But getting back to the question, if this is a low rating, well, how would you improve it in your practice?
Uh, you can say, I would like to know what's affecting your care, and I want to know more about your social situation and your support
Hmm.
system. Maybe by if we have a group practice of 4 providers, if there is a documentation, like in the
Hmm.
social documentation, if we can document every visit, like how their situation is going forward, we can review with the patient if there's any changes.
Yeah, that's awesome, Arpita. I think it has to be, I think what Arpita is suggesting, it needs to be systematic. So um, Vosker and I can talk about it and say, hey, this is a good idea. But that doesn't mean the other people are going to do it. And it doesn't mean other people are going to do it consistently, including me, right? I may not ask this question consistently. I think
We
this is a really important sort of thing. As you know, I'm on the U.S. Preventive Services Task Force. One of our upcoming topics, I can tell you, is about identifying social isolation, especially among senior citizens. Huge problem. And you won't get to that unless you ask, hey, tell me who's at home, and have that as a consistent questionnaire, as Arpita was suggesting, maybe even eventually a gap in care that appears in Epic or Cerner or whatever you happen to use.
we do have like in pediatric training while we were training for residency.
Hmm.
Social documentation is very important when we are getting the history, and all the providers have the same unique, like the same type of documentation. But when we practice in adult medicine, we don't use that social
Hmm.
documentation column. So I think it's really important training as a resident, getting that habit of doing it.
Yes, Arpita, I may ask, that pediatric documentation, is that completed by the provider or by an MA or a nurse
By
in a,
provider.
oh, that's excellent. Okay,
Yeah.
great. Great to hear. All right, Andy, next slide, please. Oh, great. I've finished 4 minutes in advance. I was going to leave 3. Okay. Any final thoughts or questions before we move on to the next part?
Goutham, can you hear me okay?
Yes, I can, Austin. Go ahead.
Hey, so once we open up the Pandora's box of, oh, I actually live alone, I live at home, I have no friends, I have no family, and we
Uh-huh.
identify the social isolation, what sort of action might you suggest, or what might be discussed at the USPSTF level, or
Yeah,
just
so
in
we're not
person?
quite there. This is a 2026 topic, Austin, but I think probably my personal suggestion would say, okay, I live alone. I do have a patient like this actually, and he is 63. He's in his early 60s. He's not quite a senior citizen. He lives alone. His parents have passed away. He is physically disabled to the point he can't get around very much. He has no siblings. He was an only child, never married, no children. And I ask him, so how is that experience for you? I don't even say something like, oh, that must be hard for you. And how is that experience for you? And he really, I mean, he almost teared up when he heard that. And he said, yeah, it's really hard. I said, well, I'm sorry to hear that. That itself is something. Now, then you can ask, I think what the recommendation will be, well, what would be your ideal or situation, or what would you like to do? This guy was a school teacher at one point, and so I made some suggestions. These are not necessarily evidence-based, to get him connected with other people in his community, which was actually out Westlake, which is quite far from where I practice. But we will look at what helps. But social isolation, I think, is really, really important. And great question. Never screen for anything and identify something unless you're willing to do something about it. That actually can aggravate the situation, right? Oh, okay, you're socially isolated. Moving on, do you smoke? Do you drink alcohol? That can be really distressing. So we have to have an intervention.
All right, thanks for elaborating.
Yeah. Any additional questions?
I also wonder if that would be a really good opportunity just to pull in the resources in the clinics as well, like care managers, CHWs, and things like that, and really tapping into the resources that are available. That's a good opportunity to do.
I think that's a great idea, Amanda. In my experience, having practiced now for whatever, 28, 29 years or so, I have not found patients that report that level of social isolation Austin was talking about, and we're happy with that situation. I don't think I think humans are social creatures, but maybe I'm wrong. Maybe some people are loners and they prefer things that way. The other thing I would say is you think people are socially isolated. Like there are people that are single, never married, no kids, no family, very few friends, but their entire social network is at work, for example, and they're happy with that. But I think it's certainly something to think about. Okay, Andy, I think we can move on. It's 8:30. This is my clinical pearl. We have 5 minutes to talk about. And from a it's hard to switch gears from social isolation to sulfonylureas, but I'll do my best here. So sulfonylureas, as you guys know, have been around for 60 years, maybe. I don't know, maybe longer than that. And they're not safe for older adults with diabetes. This is, glyburide, glipizide, glimepiride, etc. They do promote weight gain by stimulating appetite because of the sharp rise and fall of insulin. They also promote cardiovascular risk independently, clearly hypoglycemia. And the worst situation is falls. The American Geriatric Society strongly recommends avoiding long-acting ones. Amaryl is probably the worst. ADA explicitly recommends against their use unless there is a compelling need. And cost is the driver of these. These are extremely cheap. They've been generic for decades. However, that having been said, many older patients with type 2 diabetes have coverage or have the opportunity to consider better alternatives. Perhaps it means elevating your dose of metformin. Perhaps there is a way to get them on a GLP-1 or an SGLT2 inhibitor. So we are now in our second year of a project funded by the AHA. It's a multi-million-dollar project. Doctors Ian Neeland, who I think has spoken at Echo QI, and myself are the leaders of the project, but there are multiple mentees and junior people involved, and it's funded by the AHA, which means the funding will continue, unlike some of our other projects. And its project is about deprescribing, and that's a term you don't hear too much. But deprescribing is trying to get people off of medications. I was involved in a deprescribing project many years ago with proton pump inhibitors. The reason is you go on these for years and years and years, and they're hiding some sort of ulcer or worse, right? And at least thinking about stopping it when it isn't necessary is important at some point. So how would you deprescribe these drugs? Now, cost is a consideration, coverage is a consideration. But what we recommend as an initial discussion is I see you've been taking glyburide for a number of years. That medication has some problems. Are you open to discussing about stopping and replacing it with a newer medication? That's all I would say. And if the answer is yes, and it typically is, you can think about, well, what's covered, and you may have to continue the sulfonylurea, but I would encourage you, anybody who is a senior citizen who has type 2 diabetes, who's been on these for a few years, please, please, please think about deprescribing. Okay, it's just it may be intensifying metformin. It may be considering a new medication. It may be just stopping it entirely just to see how they do, because there are a number of problems, including falls, associated with it. Any questions about the clinical pearl? Okay, great. Next slide. So this is our case discussion for today. And I deliberately chose this because it is kind of a patient experience satisfaction problem. So Elliott Street Medical Associates, busy primary care practice in Columbus. Surveys consistently reveal that patients feel disrespected by staff, especially when calling for appointments or other information. Here are some questions. How would you start by investigating the problem? So this is on a survey, written surveys, right? And after gathering information, what strategies or tools might be helpful in improving the situation? A word about surveys. Um, if you put out a survey to everybody, what kinds of people are likely to respond? Well, they're quite often people who are unhappy. So that doesn't necessarily reflect a poor quality of care. People who are either okay with care or even pretty pleased with it probably not going to spend 5 minutes to fill out a survey unless they were really ecstatic with their physician or something like that. So you have to take it not with a grain of salt, but you have to be careful about how you analyze the information. Uh, in my practice, there was one lady who is chronically dissatisfied, but she herself is about 10% of all the surveys, right? So she's unhappy, and it's like if we look, she's bringing down the average basically, but she's unhappy. But you have to be careful about it. So this is why getting an experience measure is probably better than that, and then a satisfaction measure. But how? Let's start with how you would go in investigating what the problem is. Let's say this is legitimate. In other words, we have some surveys that are positive, some that are negative, but overall the score is very poor. What would you do next? Any thoughts?
Well, I think importantly, we want to know why they're unhappy.
Mm-hmm.
Was that a conversation they had with the front office, or was that uh, they were not getting a return appointment in time, or uh, the doctors didn't fully communicate with them, uh, regarding their care. So we want to find out why they're dissatisfied.
Exactly. So you want some Oscar, some process measures that you might go back to a subset of patients with. You may not know which ones are unhappy, and you don't need to know it. You don't want to call just the ones that are unhappy, right? You want to call a random set of patients, and as he's mentioned, maybe ask them, well, how was your experience? Did the person who took your phone call address you in a respectful way? Did they answer your questions? Did they offer you alternatives for an appointment if your preference wasn't available? Did they apologize for not having an appointment available? Those kinds of things. You can come up with anything of that sort. And that will, I guarantee it, as Dr. Mukherjee said, will pinpoint the problem specifically. Now, once you've done that, how would you improve the situation? It's not as easy as it sounds.
Again, obviously, if it is the front office, we want them to go through some retraining. Uh, as far as myself, uh, when I hear the reason for the dissatisfaction, I try to correct it in my ongoing practice. Um, so I guess it depends on the issue.
Mm-hmm. Yeah, it is. And in your practice, it may be relatively easy. For me, it often involves a discussion with our nurse leadership or with our clinical manager, who in turn uh, sits down with the staff members in question. That is not an easy situation. Imagine, like, you're a staff member and you're being told, oh, yeah, we've got a little bit of an issue I need to discuss with you. Some people are very defensive, some people are upset, and it can have some negative consequences. Um, a way to do it in a larger environment is to use a script of some sort or checklist of things, and to issue it to everybody, even the person that is 100% perfect already, making sure that they use this. And you use the checklist for a while until it becomes second nature, maybe 3 months or so, and then you don't need it anymore. But that might be a way to do it. Then you can look at the surveys again afterwards to make sure they're on the right track. Once you have that habit, I think hopefully things will improve significantly. But that's any other thoughts on how you might go about this?
Having like a team meetings with the staff and like not pointing fingers, but like trying to get it like a universal protocol, like this is how the patient scores are, this is what we need to do. But I think it's just understanding, as you mentioned, like what the patient wants and how, even if they are communicating well, it's just like trying to acknowledge that they did not get an appointment, saying sorry, saying thank you. Like those are the small things that really matters.
Absolutely. And I think listening to the team meeting is helpful. Listening to the staff, and not that they would be defensive necessarily, but they might say something like, "Yeah, we have a lot of patients who are extremely demanding and they want appointments right away, and we try our best to accommodate them, and it doesn't always work." I mean, that's a reasonable. Yeah, I hear what you're saying. Let's try to do better. My own experience with this, I can tell you from Chicago and a network of FQHCs, was with measuring blood pressure in children. Big problem. So we sent somebody in, some of our trained research associates, to observe, and the observation was pretty alarming. People making numbers up, uh, sticking the wrong size cuff on, not waiting, not repeating high measures. You can imagine, no, very poor technique. And this is with the oscillometric machines and not trying to measure it manually. So we had meetings. We didn't say you guys are terrible at doing this sort of thing. And we started with a protocol, the NIH protocol for measuring blood pressure in children. And of course, it revealed a lot of information to us as well when we listened and said, this is extremely difficult. Some of the really young kids in particular will not sit still for 2 or 3 minutes. And then I've got stuff to do. And if I have to repeat the blood pressure, I often forget to go back in the room, etc. So we address those issues up front. So listen first when there's a satisfaction issue, and then present it as, here's an opportunity for us to improve things together. Maybe a checklist might help. But I appreciate Arpita's suggestions, and thank you as well to Oscar. Any other thoughts before we move on?
Yeah. At
Yeah,
what
Gautam,
point would you?
Sorry, Orson, go ahead first.
Okay.
Oh,
At what point would you consider a PDSA cycle?
For this, if this is the thing that you are focused on, absolutely. Yeah, I would definitely consider it. Um, I might, after Orson doing a little investigation and putting that checklist in, if there was no improvement, let's start to look at, dissecting it into pieces and see if we can improve things. The other thing is, not to sound, sort of cynical about it, sometimes this drives things like market share and quality overall measures and bonuses and that sort of thing. So it may be worthwhile as a QI project in particular. So yeah, I would, after 3-4 months, if you can't find, if nothing's happening, and I hate to say it, but sometimes it's one person or two people that are responsible for this. So
Thank you.
yeah. Oscar, you had a comment to go.
yeah, I had a comment. Um, and this follows what you said a little earlier. Do you think that certain patients should be left out of a survey because they are outliers and they skew our stats? I mean, I know when every now and then I will have a patient when he or she leaves my office, I know this patient is unhappy. Example, patient with a blood pressure of 100 and systolic of 102 who is on a high dose of lisinopril, and I want to cut the dose down, and the patient insists, I cannot survive with a lower dose. And I know this patient is going to be totally unhappy at the end of the visit. So I don't know that. And you mentioned yourself how there's these patients mess up the stats. They
Yeah.
don't really give a true picture of
Mm.
where the practice stands.
Yeah,
That's
it's a
just
great
my
point.
thought.
So sometimes if you are investigating um, a subset of patients, let's say it's people with type 2 diabetes who are on insulin, who are over a certain age. And I don't know how big your practice is, Vasco, but mine, that would probably be maybe 40 or 50 people at most, right? And I happen to know this husband and wife pair who are both in that situation, and they are unhappy with everything. So I would consider not leaving them out. You have to survey them, but perhaps looking at the average without them and with them and see how it's different. But absolutely, I think you need to go ahead and do that. Andy has reminded me we do need to move on, so let's do that. Next slide, Andy. Okay, I'm going to turn things over to Amanda, and we are a few minutes over. I apologize, Amanda, but I think we can get back on track.
That's okay. Good morning, everyone. Thanks for joining. I think we'll jump right in just in the interest of time. I think Nate is not on from Healthcare Connection. So Arpitha, do you want to kind of talk to us about your project? How's your project going? Do you feel like you're maybe making gains or moving in a positive direction? And what do you think might contribute to that? And just how are things going overall? Just to kind of level set and get us started, just as a reminder, Metro Health Arpitha is working on increasing the percent of patients who have that ASCVD risk score greater than 10 and really focusing on getting them on statins or on a cholesterol lowering medication. So Arpitha, do you want to give us an update?
Sure. Thank you, Amanda. I was actually looking at the list of my patients. Now it came to a point where the list is mainly like patients who refused in the past or who are actually like their cholesterol is normal, but their risk is high, and it's hard to convince this kind of patients on starting on the statin. So overall, the project went very well, and I have the scores going up on patients who required statin and who started on statin. So my goal is to see if I can schedule follow-ups, which we have a difficulty. Like we are out of telehealth appointments from next week. So it's hard to get these patients come in person. But my goal is to see if I can get them scheduled and have a discussion and like follow up on them at least every 6 months or maybe every 3 months in case if their LDL is high, to see if I can get to convince them. And we are short of 2 providers who are involved in this project. So it's only me trying to do this. So I think that's one of the setback. But we have some changes in our scheduling. So the telehealth is one biggest thing that I was thinking to have discussions with the patients within a short time. But that's one other thing we need to figure it out.
Okay, so I think I hear you saying that you've made outreach to all the patients, and now that you're really left with those folks that maybe have declined in the past, or that you've had a
Yes.
difficult time getting on medication, and focusing on those patients.
Yes.
Okay. Any thoughts from the group on how to help Arpitha to engage those patients or bring them into care? Okay, well, Arpitha, we'll be excited to hear from you our next meeting on how you've engaged those patients and the outcome of that. So
Thank you.
we'll keep working on it. Thank you. Thank you for sharing. Village of Healing, Amber. just kind of level set and think about what Amber's working on. Decreasing the percent of patients with high blood pressure or those patients that are not in control, and working to get their blood pressure under control. Amber, do you want to give us an update on what you've been working on and some of the improvements you're seeing?
Yes, we've been seeing great feedback from our patients. Um, I, I really do see a lot of great like structural or documentation changes from just like our system at large. Like we're working with our Epic team to create standardized like smart sets that we're all providers are or and the nurses will use for our blood pressure nurse visits. We did our GIMPA walk, had identified that when patients are scheduled for nurse visits, they don't get return, they don't get the text message that comes through the system, and we were able to correct that. So so far, since we've noticed a little more increase in our nurse visits or just return visits or return calls for patients to reschedule if something comes up. We've standardized like the way we do blood pressure, so everyone's saying the same thing, doing the same way. We even had a patient the other day like, hey, you didn't do my average. And it was just like, thank you for, keeping us accountable. And I really, just from this standpoint, just seeing the the standard across the board being in place and being used for everyone, us all speaking the same language, really makes me feel proud. But more importantly, seeing those numbers change for those patients, seeing them change their behavioral habits, and also sharing with their friends, and getting new referrals from new patients because of the education that we're doing, and the patient-centered care that we are receiving, or the patients are receiving, has been a great turnout. So thank you for your support, Amanda. I think this is going well for us.
That's awesome, Amber. Yes, I have definitely just hearing your meetings and the success you're having there is really awesome to see. And did just want to point out that Amber's also has highlighted her success in a couple of staff meetings and created a flyer that really outlines a specific patient story, and has been able to share that with her team and really has motivated them. And then considering sharing that with other patients to help motivate other patients and see that success. So awesome work, Amber. East Liverpool. I did see a couple of folks on. Jim, do you want to give us an update on what you've been working on and some of the success that you've been having there?
Yes. So with our QI project, adjusting the statin medications to lower the LDL. So we had a meeting, I think, a week ago or 2 weeks ago. So yeah, as of our submission of data in September, so we were able to, I think, submit the data with 15 out of 20 patients that are on statin medications. And then yesterday we are also, or we have worked with our data yesterday also. So we have identified the issues that could have caused these patients to not be compliant and all that. So, and we were able to monitor their, what do you call that, next follow-up visit. So being more vigilant, because that time frame right there for the next follow-up visit will tell us the need for the to recheck, and we have communicated this with the rest of the residents also. So tomorrow, or if not tonight, we will submit our data regarding this one.
And then just to kind of add on to that, I know you guys have in the practice been working on documenting the reason for the visit and
Yes.
just making sure that all the providers know the reason the patients are coming in and some of the work you've been doing. One thing I wanted to kind of have you talk about is your new initiative, where if a patient's calling in for that lipid lowering medication, that you're checking to see that they've had that appointment or that they have one scheduled, and if not, sort of talk about
Yes.
what you're doing.
Yep, exactly. So yeah, we before we send medication refills, we have to look at what their previous laboratory picture was. So if it's not yet controlled, so we don't send the medication, we recheck the labs. We ask them to come back. Yeah.
And then if you notice that they do not have an appointment, you're sending a message to the front desk to really work on getting them scheduled to make sure that they're getting those follow-up appointments.
That is correct. That is correct. So if there's if the appointment reminder is missing, so yeah, we communicate that with the front desk that, hey, this patient needs to come back, or if it's time for them to come back, we communicate that to the front desk. We also communicate with the rest of our co-residents to be vigilant on that one as well.
Perfect. Great work, Jim.
Okay,
Thank you.
thank you.
Quick comment. Are you noting the reason for which they're not complying with their statin? Why they are not taking it?
So yeah, Doctor, we asked them about compliance. They gave us some reasons, like reasons that include but not limited to, like they forget. They just don't like the side effects of this one, so we switch them to another one. And something about logistics, like transportation issues, like my son can't drive me, or things like that. And sometimes they change their phone numbers, and when we communicate with them about, hey, it's time to follow up, or it's time to recheck labs, they change their phone numbers and we can't reach out to them, so we end up calling another family member that's on file. That's why it's become a habit also that we incorporate with our co-residents, that, hey, ask them about updated phone numbers, ask them about secondary phone numbers, because if the primary phone number is working or has changed, we need to update that in our system.
I just found out a new reason why two of my younger patients are not totally refuse to take statins. That's because there is information on the internet that they may cause ED. I mean, totally ridiculous, but they refuse to take statin for that reason. And it's a question you really can't bring up with the patient.
Yeah, they read so much information, but that's going to be for another discussion with regard to that ED.
Thank you, Vasco, for the conversation. Thank you, Jim, for sharing.
Okay, thank you.
Nicole, are you on from Erie County? Do you want to give us an update on your project and how things are going? Nicole, if you're speaking, we cannot hear you. All right, well, maybe we'll come back to Nicole. David, do you want to give us an update, David, from your perspective on how your project's going overall?
Yeah, good morning.
Good morning.
Thanks, Amanda. Good morning, everybody. We've had some pretty good outcomes recently with our program. I do want to highlight what Amber said about the reminder text for nurse visits. We had that same issue that is getting addressed, so that we do get those folks calls. So in the interim, we are just making sure that we are giving those folks a call ourselves, and not relying on the reminder notices. And the standardized BP techniques. We're doing that as well, especially with the training of our new staff. We've had an influx of about 5 new staff members over 2 offices. So it's been a good opportunity for us to put that in place to make sure that they are performing the blood pressures with the same technique as everybody else. So we've purchased a couple of training scopes just to kind of make sure that our new folks are doing what they're supposed to do and doing it the way that they were trained to do it. So that has helped us. We did identify a couple of folks who were measuring almost 10 points off, and we've had to adjust them and train them just a little bit better. So we've got one person back on track, and then the second person just about there. One of our we are doing mandatory follow-ups for patients who are on the statins and also their other medications. So we're doing the mandatory follow-ups that seem to be going pretty well. We have about a 85 to 87% success rate currently for those folks, just to reminding them that the reason that we're requiring that is to make sure that not only the new meds that we're giving them, but also the adjustment of all their other medications are taken care of timely, so that we don't have any overlapping concerns with the folks down the road. So that seems to be helping the patients. And our paramedicine, this is something Amanda and I spoke about. We have a program here that when we have patients in the rural setting that can't get here, or they're their age prevents them from coming to appointments, or they have to wait for rides, we have the opportunity to schedule paramedicine, where we actually have a paramedic go out to the patient's home for the visit. So we chart prep for the patient. We send that over to our gentleman who goes out, our paramedic who goes to the office, and then we do a video visit through him with the patient, and the doctor can ask the paramedic for certain things. They can do the lung sounds, of course, and do the total assessment. And that has helped us collect some of those folks that are only come in once a year. So we're utilizing the paramedicine much more now. It seems to be a great help for this project. So we're going to continue to monitor that and see how that goes. And I might have a lead on potentially having the ability to get some of the portable units for patients to take home, especially the ones that can't come in a year, and even some of those that don't have any type of internet at home. We can actually get them to use the units, hopefully, and record those so that we can speak to the patients and hopefully get them under control a little bit quicker.
That's an amazing resource. And just, I know we're at time, but Dr. Sherry Boland's asking, David, how do you fund the paramedic visits? And what does that funding stream look like?
Well, so currently it's just a part of, what they're doing. So its funding is coming up very quickly as we move towards the local townships, and providing a little bit more monetary involvement with the ambulance services out here. So it may change in January. Right now, it's just something that we're doing through the hospital. It's funded through the hospital. It may change next year. We don't quite know yet, but we're waiting to see how that turns out.
And David, I think we'll talk offline just so I can get some more information on how you're funding that and what that might look like to help other practices. But thank you for sharing. Andy, are you going to close us out?
Yes. So just a few reminders. We have our next cardio webinar next month on December 3rd. We offer free credit CME, and we would love if you could join us. You can scan the QR code or visit cardio.org to find the registration link. And then for our upcoming QI report outs, you will work with Amanda in your monthly meeting for November on a Pareto chart related to your QI project. And we will have clinics present the Pareto charts during the December or January clinics. And then just the regular reminders, you should have received a post-clinic survey about 15 minutes ago in your inbox. Please complete this by next Friday at 5 p.m. Otherwise, your upcoming data is due tomorrow for October. So please submit 20 patients you saw in October to the link. I just messed it up. And then our next clinic is December 4th. So email me with any questions. Thanks so much.